Thank you for joining our special webinar on telehealth in South Africa. I'm Rosemary Foster and I'll be the moderator for the session. I work with the University of Cape Town Centre for Infectious Disease Epidemiology and Research, also known as CIDA. Today we have 5 expert speakers participating. They represent several groups, clinicians, government, teaching and research, insurers, and industry. And I want to thank them for taking time out of their schedules today to be with us. I also want to thank the International Society for Telemedicine and eHealth for supporting this event. And then lastly, I want to thank Svetlana Efimova, the project director for Africa Telehealth, for helping make this webinar possible. Our speakers are going to introduce themselves when they speak. But I just have yes, if you have any questions, there's a Q&A bubble at the bottom of the screen. You can enter your questions in there rather than in the chat area, and we'll try to catch them. Rajiv, are you ready to go now?
Yes. The only thing is that my video still is giving trouble, but anyway, I'm ready to go.
Okay, so I'll introduce you. So our first speaker is Dr. Rajiv Ishwari. He's the director for eHealth at the Gauteng Department of Health. Dr. Ishwari is an innovative medical doctor who is passionate about telemedicine and digital health in developing countries. He has extensive experience working in both the public and private healthcare sectors, both in India, where he originally trained, and latterly in South Africa. I first met Dr. Ishwari almost 20 years ago when he was the telemedicine coordinator for the Eastern Cape Department of Health, a position he held for 10 years. Following that, he was director for eHealth for the KwaZulu-Natal Department of Health for 6 years before moving to his current position in Gauteng. Dr. Ishwari's career as in telemedicine has had several successes, and there have been some great projects for which he's received awards, including a critical care management EICU system for the remote management of ICUs, a population health management system using digital pens to collect information in the community, and then a teleradiology system. So if you are ready, Rajiv, we're looking forward to your presentation. Thanks.
Thanks, Rosemary, for the introduction. Can you hear me?
Yes, I can hear you.
Okay, thanks. As Rosemary was saying, I'm a medical doctor with a passion for healthcare information technologies. I'm passionate about advocacy of telemedicine for the past 2 decades. In every workplace, I've embraced telemedicine opportunities. I tried, and I have a self-driven passion in learning, mastering, and embedding telemedicine. Let me start my presentation with thanking all the amazing frontline workers who are working hard, risking their lives and taking care of all of us in this pandemic. That's my favorite slide. It says good old days. When I actually started working, we used to do home visits. Home visits will become a thing of the past with the new norm. and maybe it'll be join history now to say, okay, we used to do home visits. Opportunities for the fourth industrial revolution. Uh, Healthcare took a long time, but finally we are there. And the key opportunities are telemedicine, artificial intelligence, machine learning, etc. Evolution of health information technologies. The focus going forward is on digital health, consumer-centric and person-centric alliance with lifestyle, the new data sources that connected to the centralized health systems, example, wearables, sensors, social network. These are some of the definitions by WHO. I don't want to go through it. I'm sure most of you know it, but we started off with telemedicine, then became telehealth, e-health, now it's digital health. Digital health is to improve health and reduce health inequalities. Rigorous evaluation of e-health is necessary to generate evidence and promote the appropriate integration and use of technologies. These are some of the international guidelines. I'll take you through some of them. The ITU, the Resolution 78, Information and Communication Technologies, Applications and Standards for Improved Access to e-health services. It's downloaded in the public domain, you can download it. And that's the next one is the National e-health Strategy Toolkit. And this is a brilliant work done by WHO, and it can be used to implement telemedicine in participating countries. This particular guideline, recommendations of digital interventions for health systems, if you look at on top there, client and provider, the definitions: telemedicine, provision of health services at a distance, delivery of health services where clients, patients, and health workers are separated by a distance. And the second one of note is provider to provider, telemedicine provision of health services at a distance, delivery of health service where two or more health workers are separated by distance. We can go on, but it's a very good document to rely on in case you are planning to start something. What has been done is the classification of digital health interventions have been done, and they have classified into clients, health workers, health system managers, and data services. On health workers, if you look at 2.4, at the bottom, it says consultation. 2.4.1 is consultation between remote client and health workers. 2.4.2 is remote monitoring of client health or diagnostic data by provider. 2.4.3 is transmission of medical data to health workers. Consultations, 2.4.4 is consultations for case management between health workers. So it's every aspect is taken care of in the recommendations. This slide highlights digital health interventions overcome health system challenges. The one in pink at the bottom, it says low demand for services. How we can go around the challenges and then come up with digital health interventions. And this document has actually clarified all the interventions that we can use to overcome health system challenges. This is another document that actually helps us. It's called HIMSS Analytics, Health Information Management System Society. And what they have done is they have analytic models, maturity models for 7 different categories. The one I've highlighted here is the electronic medical records management. And if you look at, there are 7 stages, 0 to 7. In the US, there are 2,673 health facilities that are in stage 6 and 7. If you look at stage 0, it says all 3 ancillaries are installed, and then it goes up to 7. It's a very good tool to look at staging our facilities in South Africa as well as Africa if required. This is the telemedicine adoption model by Ernst & Young. This was in 2015. This has 7 levels, 0 to 7. And if you look at 0, it's emerging telemedicine program. Telemedicine operations are centrally managed. Policies are in place to ensure security and regulatory compliance. When it goes up further, if you look at stage 7, it says full interoperability. All medical device data, including data from patient-provided variables, is transmitted to and analyzed in an internal EHR. Data is easily exchanged with external organizations. So this shows that we have a lot of work to do to attain level 7. This is another area where we can look at the Institute of Healthcare Improvement. They have this triple aim. It looks at population health, experience of care, and per capita cost, reducing cost. From triple aim, it went on to quadruple aim, where they added improved clinical experience. Legislation, policies, strategies, norms, and standards. These are some of the documents that actually guide us in South Africa. I'll take you through some of them. In 2018, we had a health summit, and the document was released in June 2019, and it is on compact pillar 9. It says develop an information system that will guide the health system policy, strategies, and investments. There were 5 themes that with listed interventions. 1, integrated health information systems. Second one was standardization of health diagnostic and procedure coding systems, improving health technology infrastructure, capacity building, and skills transfer, development of business intelligence. So this was a document that has been released. It's in the public domain. It's available. The latest document now that has been released is the National Digital Health Strategy, 2019 to 2024. We had an earlier one, which was called the eHealth Strategy, but with the development now, we actually changed it to National Digital Health Strategy. National Department of Health has identified IT and health information systems as a critical requirement for successful implementation of national health insurance. We have successful eHealth programs that the National Department of Health has developed and implemented in collaboration with its partners, including Council for Research, the South African Medical Research Council, and GEMBI to improve health outcomes across South Africa. That's the vision and mission. The priorities were design, develop, implement, support, and maintain a complete electronic health record, which will improve patient management. Standardization and digitization of health systems business processes. This will include digitization of various health systems to improve efficiency and quality at an institutional level for human resources and medicine access. Establishment of an integrated platform and architecture for health sector information and interoperability use cases to allow the linkages and communication between patient-based information systems. To scale up high-impact mHealth for community-based interventions. To the development of digital health knowledge workers for successful economic development. The Health Professional Council of South Africa has developed a book on general ethical guidelines for good practice in telemedicine. This was in 2014. I don't want to go through all that, but the emphasis was to look at how technology can be used, and the guidelines were given for best practices as how the healthcare workers should go about. The latest addendum or the amendment that was done that emphasizes telehealth should preferably be practiced in circumstances where there is already established practitioner-patient relationship and where such a relationship does not exist. Earlier, it was not allowed. Practitioners may still consult using telehealth provided such consultations are done in best clinical interest of the patient. The clause C also has been amended, although practitioners may charge fees for consultation undertaken through telehealth platforms. The council strongly cautions against practice that may amount to over-servicing and perverse incentives. When it comes to history of telemedicine, if you look at this on the left-hand side, it says 500 BC, the telemedicine started. But if you look at what has been done in South Africa, in 1998, we had a national telemedicine system for South Africa was planned, and 28 pilot sites were established in 6 provinces. The initial applications for teleradiology, ultrasound, antenatal services, and technology was a bit not that advanced as now. We use ISDN. From January to September 2000, 2,663 radiographic studies were performed at the 3 Northwest Province teleradiology transmission sites, of which 64 studies were selected for specialist radiologists reporting by teleradiology. So we actually have done some work. In the private sector, teleradiology is being practiced for more than 10 years. One area of concern is related with low usage of telemedicine systems, which raises questions about its cost. These are some of the initiatives existing in South Africa, but most of them are in silos. But there is a lot of work that has already been done. Prominent among them, the Mom Connect and Nurse Connect. I'm trying to see which one I should emphasize. But in the private sector, the one that has been very well is, I think, the Hello Doctor. And there is a Vula app that is quite, it's been used extensively by health practitioners. This slide, I've been using it for quite some time now. It's improving and supporting referral systems. If you look at it across the continuum of care, we can provide telemedicine services, and we can improve quality of service that is being provided to the patients. And what is required is very simple. I mean, it's not like before where it was a rocket science. Now it's all simplified. Have a computer with connection and an internet connection and a web camera, you can actually get onto a telemedicine program. Barriers to access to telemedicine. Telemedicine barriers exist in all countries, but do not affect them to the same degree. It is difficult to quantify how the impact varies from one country to the next. Some of the barriers that I'd like to highlight is lack of acceptance by healthcare professionals, lack of interoperability of the systems, reimbursement, insufficient funding for telemedicine activities, inadequate IT infrastructure. Funding and financial incentives are key drivers for telemedicine initiatives. This slide, I'd like to highlight the triple, quadruple, and quintuple innovation helix framework. Initially, it started off in 2000 with triple helix. It's a collaboration between academia, industry, and government. Then in 2009, the civil society was added, and in 2010, they included the environment. These are some of the collaborators we can actually collaborate with. If you look at the environment, it's international cooperation, eco-innovation in academia, the medical colleges, the universities that we have, and in government, we have Department of Health that has to collaborate with Department of Telecommunication and Postal Services and Department of Higher Education. Department of Health has got a unit called National Health Information System of South Africa that actually monitors any digital health activities and interventions. On the civil society side, we have the South African Medical Association, Hospital Association of South Africa, South African Health Informatics Association, Private Healthcare Information Standards Committee, SA Medical Device Association, and Independent Communication Authority of South Africa. We have non-governmental organizations as well that we can collaborate with. And without having the research and development, we need to collaborate with Medical Research Council, CSIR, and HSRC. And the industry, the telemedicine service providers, the medical device manufacturers, telecommunication service providers, private hospital groups, and general private practitioners. Let us work together and redefine healthcare. With the coronavirus pandemic, health system researchers and telehealth vendors must see this as an opportunity to bring connected healthcare to the forefront and reshape the future of healthcare. Impact of global health in Africa. It is time to face the challenges. Time alone will tell whether telemedicine is a forward step in the backward direction, or to paraphrase Neil Armstrong, one small step for healthcare information and communication technology, but one giant leap for healthcare. I'd like to end with this slide. Opportunities multiply as they are seized. It starts with a vision. The day is coming when telegraph wires will be laid onto houses just like water, or gas, and friends will converse with each other without leaving home. This was Alexander Graham Bell in 1875. It takes courage to make things happen. We have to dream, dare, and do. I think that is where I'd like to end. But I'd like to say that now that we have international guidelines, toolkits, analytic models, benchmarking, the legislation, the strategies, the policies, digital health strategy has been approved. Health normative standard framework for interoperability has been approved. The Health Professional Council is very supportive now. Most importantly, we have expertise in South Africa that we can use to make it happen. We have to collaborate. We have to collaborate between academia, government, and the industry to make things work. Thank you.
Thanks very much, Rajiv. There was a lot of information there. Will we be able to share those slides?
Yes, I've already sent it to Svetlana, but I can share it too.
Okay. Okay, fantastic. Thanks very much. Next, I'd like to go to Dr. Jill Fortuin-Abrams from University of Cape Town. Sorry? Hello, Jill.
Hi, I'm here.
Good. So you don't have a video link there, but do you have slides that you'll share?
I have sent my slides to Svetlana. I'm not sure if she's able to share it, so I will speak to my slides.
There you are.
I am here. Hi, everyone.
Okay.
I'm sorry about that. We had some technical glitches earlier on.
Okay.
Yeah, so I'll speak to my slides if that's okay with everyone, and I'll ask Svetlana to share it with everyone, after the presentation.
Yes, and if you could just do a brief introduction of who you are and what you do. You've been in telemedicine South Africa for a long time.
Yeah. So thank you, Rosemary, and thank you, Svetlana, for having me part of this seminar today. So my name is Jo, and I've been part of telemedicine since about 2002. Firstly, with the Medical Research Council, I was working for under Dr. Morekile Molefe. And once she left, I took over from her, and I headed up the division of telemedicine and telemedicine and eHealth at the Medical Research Council. And I've been working in the sector for a while, and subsequently have moved on to the University of Cape Town, where I'm a lecturer in the division of biomedical engineering, and I focus on healthcare technology management. And my main interest, my research group, is really focused around digital health, where we not only innovate looking at potential digital health solutions, but we also evaluate digital health solutions. So that's my main area of interest. So I hope that sums it up. And so my presentation, I just basically want to take a step back into the past and look what has been happening in the telemedicine sector in the past 10 years. And from what I can see, many projects have been dormant. And there's even reports about all these dormant projects that we have in South Africa. And they've been dormant because it was just a project. And as the previous Minister of Health, Dr. Aaron Motsoaledi, always used to say, we have a plethora of projects. And every time a bin breaks or there's a needle stick injury or something goes wrong, everyone wants to offer him a digital solution. So we have all these projects, but many of them now in 2020 is completely dormant. We had an eHealth strategy.
Just a sec, Svetlana says she has your presentation. She can share it if you wish. Would you just like to keep talking to it?
I'll keep talking. I don't want to sort of hold up the process.
Thanks.
Okay. So Dr. Rajiv alluded to the eHealth strategy. So there was an eHealth strategy, the first strategy, and it lapsed. And I just want to make a note, and this is no reflection on the people that drafted the first eHealth strategy, but it took a number of years before, we formulated all this information and put it into a strategy. And then there was a lot of repercussions because there was no strategy in place. And some of them were things like the government implemented a moratorium on all e-health projects. There was legislations that were not in place for people to take up telemedicine in South Africa. So these things held South Africa back in the past 10 years. Over the last 5 years, there's been a focus on eHealth. And that's primarily because we've seen this huge influx of technological devices, the affordability has increased, and connectivity has obviously been improved in South Africa. We now recently have a digital health strategy. We have some legislation around, but not sufficient around telemedicine. We still have infrastructure challenges in South Africa, and we did not in the past 10 years have buy-in from all the stakeholders. So my next question that I thought about before having this particular seminar was, has it taken COVID-19 to move telemedicine forward in South Africa? And the answer is definitely yes. And the CEO of RicoMed, which is a company in South Africa that focuses on doing bookings for medical doctors, and their CEO, Sharan Ahmed, says it's taken COVID-19 to move the telemedicine sector forward by 5 to 10 years in just 2 weeks. And I just want to park that there, because that's how much COVID-19 has contributed towards us taking up telemedicine, whereas in the past 10 years, we've not moved much. It's been very, very slow. So what are all the things that has happened? For example, during COVID-19, the Health Professional Council of South Africa introduced telemedicine guidelines, which actually now permits health professionals to use telemedicine, to get reimbursed using telemedicine. So they've now, in the state of disaster, have agreed to telemedicine guidelines. So that is one way that telemedicine, COVID-19 has definitely moved the telemedicine sector forward. Connectivity, we have increased availability of connectivity. And I don't think that only stems from COVID-19, but also things like our 2010 World Cup. But many other events have played a huge role in the increased availability of connectivity as well as the increase in speed. However, one of the biggest problems with connectivity in South Africa is the cost. And in the last while, we have many websites that have become zero rated, meaning that if you use UCT's website, for example, and you access certain applications within the UCT website, it's completely free to you. Likewise, many of the health insurers are trying to introduce the same thing. Then, of course, the big thing that has been happening is that there's a willingness to engage by both the health professionals and the patients. Previously, either health professionals didn't want to engage using these particular platforms of telemedicine, and patients themselves were either not aware or didn't want to use it because they felt, I'd rather go and sit in a doctor's surgery and wait to be seen by a doctor, only to be told, I need to just collect some medication. There's nothing much that you can do. So what we're seeing in the publications is that more and more patients are opting not as telemedicine as their third option, but as their first option. And COVID-19 has made people realize I don't actually have to sit at the doctor an entire day because I've got the flu-like symptoms, which is not COVID-19 related or sinus or anything else. My first point of contact is using the telemedicine application. Of course, technological advances have also contributed to us moving the sector forward. Things like smartphones, affordable hardware, in general, have allowed us to use telemedicine. So my next question that I asked myself, so what is the future? We have all of these things happening, and what is the future for telehealth, telemedicine in South Africa or on the African continent? And I think the first and foremost thing is that there needs to be a policy in place. We do have a digital health strategy, but we don't really have policies in place, not just a policy for telemedicine in our daily operations, but also a policy around the use of telemedicine in the event that there's a state of disaster or a state of emergency or a pandemic. Many other countries, and you can go back to the literature, it says that countries that are more prepared for COVID-19 or who had been exposed to other pandemics or infectious diseases outbreaks like SARS or MERS, they are more prepared now. And they have policies that actually speak to what are the alternatives that we need to use in the healthcare sector instead of going to see a doctor. And so they have policies that directly speak to the use of telehealth. The next thing that I thought about in terms of the future for telehealth is the integration of telehealth services. By way of example, I just want to talk to Hello Doctor, which is one of the applications that is available in South Africa, and it's been around for quite a while. It's the integration of Hello Doctor into the health system. Not, and again, Minister of Health, Dr. Erin Motsoaledi, to quote him, he says, we don't have a private healthcare system and a public healthcare system. We have a health system, and he's the Minister of Health, which we often refer to, and now it's Dr. Zweli Mkhize. And we are talking about, for the future, the integration of these telehealth services, not only for the private sector, but for the public sector as well. This would mean that patients that are now not COVID-19, are not going for COVID-19 testing, but anything else, could go to our office or stay at home, use their smartphones, use their devices, use community healthcare workers with devices to triage using applications like Hello Doctor or services like Hello Doctor or Doctor Connect or Telemedicine Africa, whichever one that would be. And then the most important thing about the future for telehealth that I could think of was the collaboration across sectors, where it is not just about the health sector, it's about home affairs, which is our sector that issues the birth certificates, the death certificates, traces where people are. It's about the integration of other services like your transport systems, your banking services, and going across all these sectors allows for comprehensive telemedicine services to be delivered. And this is evident in many other countries where they're collaborating across sectors to ensure the delivery of telemedicine. So in a nutshell, I mean, that's my contribution towards today's talk. And I hope it's of use. It's very short, but I hope that there'll be rich discussion going forward.
Thank you very much, Jill. That was really informative. I'm sure there'll be some questions for you. I think it's actually good to move now to Dr. Michael Moll, who's the CEO of Hello Doctor, because he spoke about Hello Doctor. And Michael, are you there?
I'm indeed, Ross. Thank you so much for having me. And yeah, good to be part of this discussion.
Yes, so please introduce yourself and tell us all about Hello Doctor.
Yeah. So, Rosemary, my name is Michael, a medical doctor. We started, co-founder of Hello Doctor. There were three of us started Hello Doctor in 2011. Jill mentioned something that the CEO of Recommended said about in the last 2 weeks, we've seen more movement in telemedicine than we had in the last 10 years. I can vouch for that. We just before COVID, we're doing around 3,000 to 4,000 consults a month. We now do 1,000 engagements a day, and this is teleconsult, so it's literally off the charts. But to take you a little bit further back, for the last 10 years, I have been lobbying with a number of regulatory bodies, the Health Professions Council, most notably for telemedicine. Unsuccessfully so until the 3rd of April, when those guidelines were amended. But it was interesting, the very practical outworking of that was I got a call from a prominent doctor, a professor in fact, who said to me, Michael, for the last decade, you've annoyed us. We've been angry with you and upset with you. Now we're all saying, please help with COVID. So it's amazing how telemedicine has been the bad boy of the industry, as it were. And by that, I'm obviously referring to a doctor-patient telemedicine service. And all of a sudden, it really becomes a service that we can use to keep people away from our hospitals and manage COVID in their own home. So I wanted to take 10 minutes just to quickly tell you a bit about Hello Doctor and give you our story in terms of how we've done a private-public partnership and just what the outcomes of those were. So I'm going to share my screen very briefly with you. There you go. And let me, in fact, start that presentation so you don't need to see all of that. Hello Doctor, my final year in med school, I will never remember my professor van der Berg, Adip van der Berg, a great guy, final lecture, told us around 70% of all the patients we see one day as general practitioners won't need to see us, which is a horrible thing to hear at the end of a long period of study. But it turns out he was absolutely spot on. I came across this study some years ago. It was a study out of the American Medical Association. 70% of physician visits and 40% of hospital visits to ER can be handled by a phone call. It was an American study. We've seen a similar study in South Africa in 2012 that showed very similar statistics, which essentially means 7 out of 10 visits to doctors don't need to take place and could have been dealt with remotely, which is where telemedicine jumps in a big way. And that's really what we started Hello Doctor on the back of. It morphed in the beginning. We wanted to replace this face-to-face visit, and it really got to a point where we realized Hello Doctor is never going to, or remote telemedicine is never going to replace that face-to-face engagement with a doctor. What it does is it fulfills that role of, Joel mentioned, primary healthcare. It's almost pre-primary healthcare. We really answer only one question when it comes to the service we provide, and I've described the service as tele-triage. And that's simply this: do I or do I not need to see a doctor? That one question every patient asks at some point, in fact, 2.4 times a year on average, do I need to see a doctor? And what we're saying is 70% of the times, no. But how are you to make that decision? Because you're not medical, as I'm speaking to the patient. So we're here to actually answer that question for you. We're not a bot. We're not AI. We're human beings, qualified medical doctors that understand you, your language, your environment, and we can answer that question for you and say, yes, you do, or no, you don't. And what we found, I'm going to jump through some of these slides, come back to that, is that 71% of all our engagements over the last, and we've been online for the last almost 10 years now, 9 years, 71% of all our engagements, and there have been tens of thousands of them, have been resolved telephonically, and only 29% have needed to be referred. It's slightly different in the public healthcare space. I'll speak to that in a moment. But we literally, and that's not a study, that's the last 10 years of data, that we found that 7 out of 10 calls were resolved telephonically. A stat that I just kind of whipped over, this was Google's Connected Consumer from 2017, 1.4 devices per person in Africa. In other words, there are more phones than people in Africa. And we just thought if we could manage the healthcare crisis on this continent, you've heard that stat, 25% of all the healthcare issues, 3% of the healthcare workers, and 1% of the funding, or something like that. If we can manage that with one device that everybody has more than enough of, 60% of our smartphones, we really can put a dent in the healthcare situation in Africa, and that's really kind of the basis of Hello Doctor. So as a service, a consumer, all we're saying is you get access to doctor within 1 hour in any language of your choosing, on any phone, anytime, anywhere. That's the promise. And we've lived up to that. I think our SLA is close to 98, 99%. And it doesn't matter what phone you had. You can have a basic Nokia 6210. You can have the latest iPhone. You can access that service on USSD on the website. So that's really Hello Doctor in a nutshell from a private perspective. So we took this to the Department of Health in the Western Cape and said, we think this service would be really well suited for the public healthcare space. We'd like to go into Delft, one of the poorest communities in South Africa, in Cape Town, and provide the service to them for free. There are 2 clinics that service Delft, and all we did was we created a USSD number. It's a string that you dial on your phone, and that gives you access to Hello Doctor services, which is what we did. These are the 2 clinics that service Delft. There's Symphony Way, and there's the Delft Public Healthcare Facility. We put up these posters and we went to the clinic. In other words, we didn't put billboards up in the community. We just went to the clinic where people were already, and we put up posters that simply said, dial this number. It's absolutely free. We reverse charged it, so there's no charge to the user. They didn't need airtime. They didn't need data. It was one number that got them straight to a doctor. And our doctors engaged with them. We knew that they came from Delft, and we dealt with the issues as we could. And it was either stay in the queue or you can go home. We did some murals as well, just to make sure everyone knew exactly what that number was. Over 10 months, this is the study that I'm sharing with you now, we had around just under 10,000 callbacks. Now remember, patients don't phone into Hello Doctor. They request a callback. Our doctors call them because it's zero cost to the patient. You have to register. You've got to give us your ID number, your name, and hopefully your file number, because that links up to the central data warehouse. I see Andrew Bull is on the call as well. Did some lovely work with him. He did some lovely work with us. And these are kind of the bit of feedback we had with this service, the public healthcare space. It took around 17 minutes to respond once someone had made a call, a request for a callback. We compared that to average waiting time in facilities around the country, which is 2 to 5 hours. In fact, a patient said to me in the clinic where we were doing a little bit of work, said, you know why they call this a day clinic? Because you've got to wait the whole day to be seen. And we understand that, and we know the frustration of that. Another lady, in fact, came up to me and grabbed me by the shoulders and said, "Ach, dankie, dokter, nou kan ek my was goed gaan doen." For those who can't speak English, now I can go home and do my washing, was her kind of joy in that sense. So 17 minutes, you're speaking to a doctor on the phone. On average, our doctor spent around 7 minutes with users on the phone. I think on average, it's around 13 minutes when you're seeing someone face-to-face, a clinical healthcare practitioner of sorts. Statistically, 75% of women use the service. Nothing new about that. Those are the health seekers in our communities anyway. But what was interesting is around 18 to 35 was by far the majority of users who use telemedicine. And it was fascinating. I had an incident with a mom and a daughter waiting in the queue at the Delft clinic. Explained to both of them how the service worked, thought to use the service. Got a call back from the doctor, got up, went to the pharmacy, collected a medication, under, came back and within 15 minutes, sitting next to mom, went to the medication, ready to go home. And I said to her, "Mom, well, don't you want to do the same thing?" And she was adamant. She said, "No, I'm here to see the doctor." And it was just one of those, it's a generational thing. Someone's going to come and they've spent their time, they want to be seen, they want to get a stethoscope put in their chest. No amount of telemedicine is going to change that. These are the statistics for the public health space. So remember, privately, we had 71-29 was our non-essential to essential. In Delft, we found this statistic to be 61% non-essential. So these individuals were in the queue, they got up and they went home once they'd engaged with our doctors, and 39 or 40% were considered essential. Now, some of the essential stats, I think, have been overstated. We've had a number of calls of people phoning the service saying, "I need a circumcision." And our doctors often say, "Well, what kind of phone do you have?" Because that'll be really difficult to do remotely. So some of that is almost overstated because people are still getting to understand what the service can and can't do over the phone. What is really interesting is of the non-essential individuals, these are people that didn't need to be seen face-to-face by a healthcare practitioner, were able to go home and leave the queue. Only 42% of them needed any form of medication. And remember, that medication is Schedule 2 or less. We, in this country, are not allowed to prescribe Schedule 3 or more remotely, which is really low, which really plays into the whole aspect of advice is what, or reassurance is really what so many patients need, not medication. This is a great statistic. This is from June in 2018. We started tracking where individuals were calling from because once we launched into the community and in the clinic, we obviously wanted them to call from home, not be in the queue when they made that call. And we got up to 83% of callers coming from home, which is exactly what we wanted. I can dive into the details here, but essentially that's what it costs in terms of government spending on healthcare per person. Hello Doctor was told in the Department of Health, particularly just in this area, 40% of those costs alone just to using a telemedicine service. My final slide, when COVID happened, as I said to you, we were doing 3,000-4,000 consults a month. We're now doing 1,000 consults a day. Let me just move my video here so I can see what the statistics are. So this is in the last 10 days. We've had, and all we did is, you can see on the left-hand side of your screen, we took the number that we used for Delft and we converted that into a testing number and really just a number around COVID. And what we found in the last 10 days is we've had around 25,000 USD users who dialed that number. The COVID helpline, you dial the number, you go through a risk assessment, asks you a couple of questions, and then lets you know if you're at risk or not. If you're not at risk, we divert you to an FAQ with a whole bunch of information on COVID, all free, no charge to the user. If you are at risk, our doctors call you back and engage with you, and then actually refer you on to tests through Solidarity and Discount. There's a nice little initiative there. And what we found, and this is really just to show you statistically, of the 25,000 users that engaged on USSD, we only did 5,000 consults. In other words, it's around a 20% hit rate of people that did require a doctor to call back. Of those, we only did 882 test referrals. In other words, 3%. So that's from the 25,000 people engaged with us, only 3% needed to be tested and were tested as a result of the service, as opposed to 25,000 people turning up at the clinic wanting to be tested or wanting to be treated for COVID. And for me, that's a great statistic about telemedicine or teletriage service can make a real difference in a state like COVID, but even more so in terms of a service that says you don't need to see anyone face-to-face just yet. First, pick up your phone and engage with a healthcare practitioner before you go anywhere. And I think that's the beauty of a tele-triage service. And again, I say that very carefully because we're not trying to replace that face-to-face visit. I don't think you ever can do that as a medical doctor. I know you can't, but what you can do is you can take the non-essential visits out of the system at great cost saving to the public healthcare space, to the users, to patients, just through a basic teletriage service, like Hello Doctor. And that's it. Thank you. Rosemary, back to you. Let me unshare my slides.
Thanks very much, Michael.
Cool.
Thank you. Yeah, nothing talks like numbers, and the teletriaging that's very powerful. Dr. Moretla Malefi, are you available? I don't know. Perhaps we, Anna, are you ready to speak to us?
Yes, I'm ready. If that works now.
Yes, so please.
Trying to set up the video.
Anna Endres from Discovery Health. So hello, there you are.
Hello, everyone. So Rosemary, thank you. So let me just very briefly introduce myself. My name is Anna Endres. I work at Discovery as head of the strategic health services there. One of the strategic health services is the digital health platform, which includes an electronic health records called Health ID and a telemedicine solution called Dr. Connect. And so I was thinking of focusing on saying a little bit of the story of Dr. Connect, just like Michael, and take you through some of our future investments into telemedicine and what we really want to continue to focus on. So just like Jill that spoke around the challenges for telehealth that were experienced until this COVID crisis. But then once, the regulation shifted and the motivation really of both doctors and members really and patients really increased, that we've also seen the demand for telehealth rise sharply. And just like Michael was mentioning, we at Dr. Connect have seen an increase of 12 times the demand for virtual consults versus last year. We've had our solution in place since 2017, with continuous increase, but nothing, as dramatic as we've seen, since the last 3 months. Maybe, if numbers are interesting to everyone, I'll share some of the numbers. Since we've launched Dr. Connect, we've had nearly 6,000 doctors registering on it, and more than 50,000 members, Discovery members actually using it. And in the last 3 months, we've actually seen the engagement with the solutions just rise sharply. We've had more than 100,000 member logins in the last 3 months. And we've got a slightly different setup at Dr. Connect, given that our triage is a self-triage made on the website. So if people are looking at, for instance, a COVID consultation, we will actually ask, whether they are feeling any symptoms, whether they've been in touch with anyone confirmed of COVID. And so once they pass through that, light triage, then we open up the ability to do a virtual consult with the doctor. And since 3 months ago, we've actually been able to conduct 13,000 virtual consults post-triage that were initiated. So that means that, some of our most engaged doctors have done 500 consults in the past 3 months, which is really staggering versus the numbers we had before. So our solution has been in place since 2017. However, this offering was adapted really during this COVID crisis to meet needs of the country that was experienced this pandemic. And so what we did was that we launched at the very beginning of April, we launched the ability for this Doctor Connect platform to be used by any South African, and actually for COVID-related consults to be used for free. You know, between Discovery and Vodacom, we've put together a fund that would pay out to the doctors to be able to do this virtual consults to any South African that was suspected of having COVID. So that was really the first step to making this Doctor Connect system open to all, both members and non-members. We've been very pleased with the uptake. We've seen, since we've launched that COVID-related website, we've seen more than 150,000 members and non-members actually go to the websites and read about the information, understand whether they feel that they've got any of the symptoms and whether they want to therefore start a consult. And so we're now thinking about the future, and really pleased with the engagement, the feedback we've had, and thinking how can we continue to extend and make the experience of telehealth better. And there's roughly 3 areas that we continue to invest heavily in. One area is how do we make the journey of telehealth augmented and even more convenient to everyone? How do we link telehealth with remote devices that can help the doctor measure and see what's wrong with the patient? How can we make the telehealth journey even more convenient? How do we plug in, you know, medicine delivery in less than an hour? All these home delivery services have been in high demand during this COVID times as well. So how do we plug in some of these services, etc.? So we really want to invest in the end-to-end journey of telehealth. We've also then started looking at how do you use the virtual consult into a number of other use cases. So not just, you know, when a patient needs to talk to a doctor, and you know, not just in those instances, but when a home care nurse, which we've got home care services running from Discovery, when a home care nurse wants to access a doctor, or when a patient wants to access some health coaching, or when a patient wants to access a nurse who is keeping an eye through remote monitoring devices on the chronic condition of that patient, etc. So we are really taking the digital solution of telehealth and expanding its use cases across a number of other settings and situations. And lastly, we're trying to link it to all of the, and given that Discovery is known for our incentive and behavior change knowledge, we're really trying to understand how can we further incentivize the uptake of telehealth and other digital health solutions with the broader population, whether that is the member, non-member, doctors, etc., etc. So we're also investing heavily in creating those new incentive programs to drive digitization as well there. So this is just a short summary of some of the things we're doing in the telehealth space, but I'm happy to answer any questions around this as well.
Thanks very much, Anna. Thank you. So we have Dr. Maretla Malefi online now. Dr. Malefi, yes. You want to you wanted to speak briefly about your project, Medics Caring for Frontline Workers.
Yes, thank you very much for inviting me to this webinar.
And I also wanted to know if you would maybe address some of the issues with reimbursement challenges.
Okay, I'll deal with that as well.
Thanks very much. Thanks.
Thank you very much. Maybe just for, I think I know most of the people in the group, but for Anna, I think Anna is the only person I have not met personally. And I'm a medical doctor. I've been in telemedicine for 20 years. I know that it's 20 years because my son was born when I started telemedicine. So I was at the Medical Research Council working with Jill. So I've worked with a number of people who are in this group. And yeah, I'm still very passionate about it. We've done a lot of projects in the country. And I know everyone thinks connectivity is no longer a problem, but we've got 14 sites in Limpopo with very expensive equipment that's just sitting there as white elephants because of the connectivity, because we used the CETA network, which is not working. Recently with COVID-19, Dr. Khosi Letlape, whom you all know is the president of the Health Professionals Council, contacted me and said, you know, our healthcare workers, whether it's nurses, doctors, or, you know, other healthcare workers, they are really in trouble because now they are in the front line. And we've realized that psychiatry is, and their psychological help is quite an important thing. And so what we partnered with the Association of Psychiatrists, and we are currently, I mean, there's a helpline from them. And if a patient, so we've got about 500 doctors, psychiatrists and psychologists who've offered their services for free to healthcare workers who are in the front line. And I think it's one of those projects where as healthcare workers, we can look after our own. Yes, we'll go to the patients, but if the healthcare workers are not in the right state of mind, then we are even in more trouble. I'll give an example. In the Eastern Cape, there's a hospital. So this doctor, he's actually a professor. He was my classmate. He sent us into a group, on a group of doctors to say, there's 2 of them, there's 25 patients that need deliveries. And they're actually cleaning floors because the cleaners are not there, the nurses are not there. So I think there's a wider issue that we need to deal with, especially with COVID. We actually need to categorize all of these things. But also maybe when I raised a hand when Rajiv was talking, I also think provinces know what they want, but it does not translate into the municipalities. So municipalities don't know what to do. Even if they need services, telemedicine services, they actually don't know where to start, what are the rules for their provinces. So I do think maybe as a group, those are some of the issues we should be handling, to say, how do we make sure that it goes down to the municipalities? Because I'll give an example. Gauteng, City of Joburg, called me and said, give us a proposal for 3 clinics, 1 in Alexandra, 1 in Soweto, 1 in the Vaal. But once you give them a proposal, they say, but what are the rules of the game? Are we allowed to do this? So I just think maybe what should come out of this webinar is us drafting something that says, how do we engage municipalities? How do we assist healthcare workers in this COVID environment? And thirdly, how do we then help patients directly, like Michael was saying, that they've seen a surge in terms of people now using Hello Doctor, which, I mean, he knows we've been fighting for them for a number of years. So I think for me, it's the outcomes of this. How do we make sure that after this, we can do a 2-pager, even if it's to the minister, to say, these are the things we think should be taken, because the strategy, and I mean, we've all been part of that strategy, but implementation, we need to talk about these practical things that are happening in the clinics and in the hospitals currently. And I'd like to congratulate Rajiv for his project in KZN, which I did with him, the Tele-ICU, because KZN Department of Health has now realized that they need it. So I think that's about it. But also to see how we can, the private-public partnership model is very important. And I liked what Anna said from Discovery. We need to look at that private-public partnership model, because without that, then we have two separate systems. And it's not really what we want as a country. So, but thank you very much. And I would like us to come up with outcomes in terms of how do we want to take this forward? Yes, we've had the webinar. How do we take it forward? Thanks.
Thank you very much, Maritla. I think we have time to discuss a couple of questions. And for me, one of the things, it's very clear when you go onto the website of the Health Professionals Council that this exception that they've made in their regulation will not persist beyond the pandemic. And it would be a shame if some of it weren't to persist. So do you have any thoughts on that, any of the panel? What are the chances of this being the point at which the regulations are permanently revised?
I think with what I've just described with dealing with Dr. Letlapi, I think we can even write him a letter to say, because I have discussed some of those regulations with him, and some of them don't make sense. So that's why I think as the people who set up this webinar, can we have proper outcomes to say, we would like Dr. Letlapi to address us, and we would like to deal with the issues, because post-COVID, and we don't know when it will be post-COVID, but we would like them to, I mean, Professor Mas has written documents and documents to the department, to the Health Professionals Council, to say, these are the guidelines in other countries. Can we really move forward? So I think we should just move forward. And I'm willing to take that task because I deal with Dr. Letlapi on a daily basis.
Yeah, that's excellent. And then what about the question of reimbursement? I know that the reimbursement, the claims that are covered by the insurers, it's nowhere near the cost of a full consult. I think it's about 60%.
Yeah, I think Anna should actually respond to us on this, because Discovery came out and said they will only pay 60% of the actual consultation. And the question, and I mean, this was on social media and people were asking, but why 60%, especially during this time? So maybe she should explain to us why they would like to pay 60% of a teleconsultation. Then secondly, I think in terms of the department, I mean, provincial hospitals and all, it's easier because they use their own doctors internally. So the reimbursement issue is not a big problem. But going forward, I would like to see us actually making sure that medical aids can pay for teleconsultations like in any other country. I mean, if you look at the US now, the telehealth surge during the COVID has just increased, and the reimbursement models are there. We can learn from other countries. You don't have to reinvent the wheel.
Should I jump in with regards to the reimbursement question that was posed?
Yes, please do, Anna.
Yeah. So Discovery actually pays 75% of the face-to-face consult rates when it is done virtually. it was the decision around that the 75% was actually not done in isolation of an international research. Internationally, this actually tends to be slightly lower. Around 2/3 of the face-to-face rate is what typically gets paid by insurers for a virtual consult. We wanted to go a little bit higher than that, because we know that we want to also encourage the shift to digital platforms. So we didn't want doctors to be discouraged from actually doing the virtual consult. We understand that because of that shift to digital platforms, one of the things that we ask of doctors to do when they do the virtual consult is that they actually submit a small clinical note for the consult, for us to be able to validate that actually a consult took place. And when it comes to disciplines where there is absolutely no difference in the quality of care ever between seeing face-to-face versus seeing virtually, which is the case of psychologists and psychiatrists. For those, Discovery has actually agreed to pay 100% of the face-to-face consult rate. So just this is not my area of expertise. I'm more the digital person, but I do know that it was all based off an international review of standard practices, and those were the rationale that was used for the current funding.
Thank you very much. I think we have time for one more question, and this is something one of the audiences asked. Is telehealth being used in HIV care? And more specifically, are there any examples of telehealth being used to support nurse-initiated and managed antiretroviral therapy? I don't know if any of the participants can answer that.
Yes, we can. I think there's been a lot of work. There's been a lot of work in South Africa, especially on HIV care, in terms of supporting nurse-initiated practices. But also remember, we also have all of those reminders for patients to take their medication at a certain time. So there's been a number of mHealth initiatives in the country to support HIV management.
Thanks, Maritla. One more question. How does telehealth address the issue of data integrity? Any takers?
Hey, Rosemary, I'll take that. I think I just responded very briefly to that on the chat.
Okay.
It's all encrypted, it's all recorded. That's how we do it. I mean, it's different for everybody, I'm sure, but it's a huge issue. Obviously, data integrity is a big thing. What we found when we launched a business in Kenya, the issues were the Kenyan Ministry of Health wanted data to stay in Kenya and not be ported to South Africa. So there was a bit of an issue there. And I think that's all part of the regulations that Rajiv talked about a little earlier in terms of countries understanding the need and the policies around telehealth. That still needs to kind of get figured out. So from a safety and security perspective, we tick all the boxes. Obviously, I think if we didn't, that would be dangerous for us as a business.
Yeah.
But I think the big issue going forward is country policies for telemedicine, and that kind of blows into the whole electronic health record issue as well. Who owns their data, who's got control of the data, et cetera, et cetera. So a very big question, and I don't think we've properly answered that yet.
Yeah, but it's a very important one. So I think on that, we'll say thank you to all our participants. Thanks very much for giving up your time this afternoon. I think everyone found it really interesting. Yeah, and thank you to our audience. I hope you've learned a lot about what's happening here. And we look forward to taking this forward and making some changes there. Thank you.
Thanks, Rosemary.
Thank you very much.
Thanks.